Good afternoon, everyone. Welcome, everybody here. Thanks for coming. Our affiliates and branch communities, as well as our four-star alliance partners, our veteran support organizations, and everyone who works with veterans to support and to assist veterans, their family, and caregivers across the country. Really appreciate you all being here today and joining us. Today's battle rhythm and federal and community view of the Mission Act is a panel discussion. To better accommodate this panel and the topic for today's webinar, we're not going to have breakouts like we typically do. We'll just have an extended question and answer period. Daryl Owens, the Director of Government Relationships at AWP, will act as today's moderator for our panel. Daryl is a veteran and continues to serve as an Army Reserve officer. Before joining AWP, he was the National Security Advisor and Military Legislation Assistant for Senator Pat Toomey, handling the Senator's military, veteran, foreign affairs, homeland security, and intelligence issue portfolio. Thank you, Daryl, for coming today. I really appreciate you being here and for convening this panel. So, Daryl, the floor is yours.
Hi, everyone, and good afternoon. My name is Daryl Owens, and Allison, thank you for the introduction. And today we actually have a great panel. So hello from Washington, D.C., first of all. On this panel discussion today, we're here to talk about the Mission Act, what it is, why it came about, why it was needed, how it's been implemented, and what the impact is for veterans. And so to start with that, today we have two experts on this who are offering both the federal perspective and the community care perspective. So we'll start, I'll do a quick introduction, I'll let them introduce themselves because we have such distinguished panelists here. I want them to kind of walk you through some of their background. First is Christine Hill, and I've had the honor and pleasure of working by, with, and for her up on Capitol Hill. She is a subject matter expert by all means and measure on Capitol Hill for everything health related. She's currently the subcommittee director for the Subcommittee on Health in the House Veterans Affairs Committee. So Christine, I'll let you introduce yourself from here and take it away.
Well, thanks, Daryl. Hello, everyone. Like Daryl said, I'm the Health Staff Director for the House Committee on Veterans Affairs. I've been with the committee now for about 10 years, probably the longest I've ever held a job. But I'm a retired Air Force officer, spent time on the Senate side working for Senator Elizabeth Dole, worked on the Base Closure Commission, was an assistant secretary over at the VA, worked in a nonprofit, and then came over to the House. So I've kind of hit all the little corners there that are needed. I've been, when I came to the committee, thought it was a rather sleepy little committee, but right then was when the access crisis broke in 2014. So have been around from the creation of choice and then the kind of refinement and revision of mission and then this latest expansion with PACT. So have kind of been seen quite an evolution in VA healthcare. So it's been pretty exciting.
Christine, thank you. I think so. Those are some of the biggest reforms I think we've had at the VA in probably decades. You've been there, in the driver's seat for most of that. So thank you for all you've done so far on that. And we'll get to more of those issues in a second regarding some of the scandals that happened, and then the Choice Act and how that all came about. And then for now, let's turn over to Jim Lorraine for a quick introduction. Jim is the president and CEO of America's Warrior Partnership. He's a good friend and mentor, and he's been in this veteran space for a long time. But Jim, I'll turn over to you real quick, sir, to let you introduce yourself.
Sure. Thanks, Daryl, and thanks, Christine, for joining us. Jim Lorraine, Air Force officer, Air Force nurse, retired as a deputy command surgeon at United States Special Operations Command. The next day, I founded a program within SOCOM that advocated for all the wounded, ill, or injured. So that was back in 2003, 2004, and then we founded the program in 2005. Then ran that until 2011 and came to Augusta, Georgia, where with myself and another partners that we have in the organization, founded the Augusta Warrior Project. Took 157 homeless veterans down to 7 in 18 months. With that success, we had a lot of support to expand our model nationally. We're now in 9 communities throughout the United States. And then we have a program called the Network. And the network this year it'll serve 2,300 counties throughout the United States with an 85% success and closure rate. But the majority of our counties, the communities that we have, are rural. Alaska being the largest geographic area, and the most remote being the Navajo Nation of Arizona, New Mexico, and Utah. So I'm excited to talk, especially about the Mission Act and community care, because it affects all of us.
Thank you, Jim. Yeah, community care is essential for a lot of veterans out there today. And before we get to talk about the Mission Act, which let me get my acronym right here, it's the VA Maintaining Systems and Strengthening Integrated Outside Networks Act. Bravo, Christine, on the acronym. That's impressive. That's definitely a mouthful. Mission Act is just a much better acronym. So before we talk about the Mission Act, let's talk about the history of it. So Christine, can you talk a little bit kind of about the some of the scandals that happened at the VA that really kind of put in highlight some of the wait times that veterans were having right now, and why community care and reforming access to care really became a priority for Congress, and then kind of go into some of the Choice Act as well?
Sure. VA has always offered community care as part of their healthcare package. This is not some new invention, but prior to 2014, a lot of the medical center budgets, or if you've been in the military, you kind of get to the end of the year and you have to spend all your money. A lot of the medical centers kind of had their one budget and tried to hold a lot of the money inside of VA, and were not as quick to refer veterans out to the community until, it became clear that they had the funds at the end of the year. And just this kind of broke with Phoenix, when there were a lot of kind of wait lists that were, kind of being maintained outside of what would be considered the structure and what veterans had access to. So choice came about as a way to kind of address this and make sure that veterans weren't waiting an inordinate amount of time for care, especially mental health care. There's a real concern there. So that's the first iteration of Choice came about, recognizing that, a VA medical center or even a CBOC can't be in everyone's backyard. And looking at some of these highly rural areas that really had a hard time accessing care. And it wasn't just about wait times. It's also about distance. Consider, an elderly veteran who has vision problems and whose driver is probably a spouse. And to go get, fitted for eyeglasses for a 2-hour drive just doesn't make sense. So that's kind of what started the whole impetus for Choice, and why we looked at more than just wait times, but also drive times, also medical appropriateness. Just because you're within 30 minutes doesn't necessarily mean that that's the most appropriate place for you to go. So Choice started, and they had a lot of growing pains. This was a new way of looking at care in the VA. And so with Mission, we went a little bit further, took a little more time to try and revise and lessons learned and things like that from what we saw in Choice. But, there's been concerns about, you're privatizing VA or you're taking care away from VA. And part of Mission, we made sure that, there's a separate budget line for community care, separate budget line for VA care. One does not take away from the other. It's additive. It's also, we have seen that with the expansion of community care, more veterans are utilizing in VA care. So it kind of, rising tide rises all boats. So that's what we've really seen, is that, more veterans are choosing to go to VA because they have more options. And, and if the care in a VA is in proximity to where they live, and it's good care. So, there was never any, we're taking one thing away to, at the expense of another. So that's kind of the big picture of the evolution of Choice and Mission.
Thank you, Christine. Let me ask Jim a question here real quick. So Jim, we're talking about community care and what it means for communities and for veterans. Can you explain why community care had such a big impact for veterans, and why the evolution from both 2014 scandals into the Choice and then to the Mission Act was so revolutionary for a lot of veterans, and how it expanded the access to community care?
Yeah, I think especially in the rural communities, but even in the urban communities. You know, I live outside of Augusta, Georgia, so I don't live too far from a major VA medical center. But in terms of wait times, it wasn't a distance issue. A lot of the times sometimes it was weight. And sometimes you have conditions. I had a client in Augusta that I was helping who had epilepsy. And you can't wait. If you can't get an appointment within a set, maybe a couple of week period of time, you can't wait 2 months for that care. It's detrimental to your overall health. But so the Mission Act gave you a chance to say, do you go locally or do you not? I think what it did and what it does, well, let's use Alaska. What it does in Alaska is allows the use of the indigenous corporate hospitals, which you may not think of it, but they're some of the most beautiful hospitals you'll ever see. And the point is that they're out in rural areas for the indigenous population of that region. But the state director, Verdi Bowen, figured out how they can be used under the Mission Act. So people don't have to travel back to Anchorage to go to the hospital. They can go to the local hospital, and it gave them an opportunity to do that without having many exceptions. The other thing it did was it made it somewhat easier. The biggest issue was you just had to be aware that you had the opportunity to do it, because it wasn't always the first thing that was presented. It was, well, let's figure out how we get you into the VA care, and can you travel, and what's the timing look like? When in actuality, it should have been sometimes could be the first thing to go to. By the way, Christine, I've got to ask on the committee side, when you guys were coming up with the Mission Act, was it 1 bottle of wine or was it 2 or 3 bottles of wine to come up with that acronym?
That's classified.
There you go.
Thanks, Jim. Thanks, Christine. So Christine, we saw this evolution then, as Jim said, that having a choice, really became big for veterans at some point, even back when choice was first around. What were some of the big changes from choice into mission, and what is the Mission Act now? Where are we right now? What is it? How can veterans use it and get involved with it?
With Mission, we wanted to, establish certain access criteria and had the secretary weigh in on that. And then also kind of clarify who's eligible and make it a little more also choice was a year-to-year type thing. And we wanted to make Mission the permanent way forward. So Mission now, with the access standards for primary care, mental health, and non-institutional extended care, it's a 30-minute average drive is the distance, and then a 20-day wait time. And then for specialty care, it's 60-minute average drive time and 28-day wait time. What we found, and this, we keep refining Mission. And right now we have a rather large package that we're working through with our Senate counterparts and also our Dems over here. We're working through some further reforms, because every as you see, as this program evolves and it grows and it matures, we also see where there's areas where we can do better. And one areas that we identified early this year, or actually late last year, but we had a hearing on it with the health subcommittee, was talking about residential rehabilitation, substance abuse, mental health, intensive, not institutional. We're actually in residence. So VA had been interpreting Mission as to not include that. So one of the areas we're still working through right now is to try and make sure that, if a veteran identifies a need to, they admit, I have a substance abuse problem, I have a severe mental health problem, I'm at a point in my life where I just need to go into some intense treatment. There shouldn't be a bureaucratic delay and a couple months, and we'll see if we can send you 2 states over, or it became very clear to us that when the need was identified, VA needed to get that veteran either into a nearby, and it's a veteran's choice. I mean, if the veteran wanted to go several states over for in the residential VA program, that's great. But if for some reason they're 5 visits over and they're like, well, there's one just 2 blocks away, we just wanted to make sure that that kind of priority was recognized, and again, putting the veteran first. That's not the bureaucracy, not the paperwork, not the, well, we have space over here, but we don't have space over here. It's what does the veteran need first?
Thanks, Christine. That's really helpful. I think Chairman Boss and Ranking Member Moran and many others in Congress have made that an absolute priority. Veterans come first, period. And I've heard that quite often in testimony on Capitol Hill. So taking it from there, Jim, let me ask you a quick question. So why community care? I mean, in the past, the VA has opposed a lot of these reforms going forward. But as Christine mentioned, the Hill has been very, very straightforward about saying veterans must come first. Why is it important for veterans to have that access to community care? Why is community care important?
Yeah, I would argue it's veterans first, but I think that the families benefit from it too. So when you think that a lot of the transportation, some of the times it's the families, I'm always a believer that if you go somewhere far away from your home and you go to treatment and then you come back to home, you're really not rehabilitating or recovering back at home. It's not, there's no connection. I think that the families, whether it's transportation or time or visitation or, people don't heal by themselves. As a nurse and a critical care nurse, when I would work in the ICU and I'd have a patient come into the hospital without a family member or anyone to support them, I would, and I worked in cardiac critical care. There was always a lower likelihood that they were going to leave that hospital in good shape because they didn't have their family with them. There wasn't an advocate for them. There wasn't somebody who was there with them as a continuity. And when you're talking with Christy's talking about going 2 or 3 visits over, your family may not be there with you when you're going through this treatment and recovery. I've always also been a big proponent of it's not just time, how long you have to wait for an appointment, or distance, how long you have to travel to appointment, but there's also a piece of this which is continuity of care. And I think the continuity is if you can go local to get your care and you can go to a physician or a provider and then their network of service providers that are local, you're going to have a better outcome. And so when we talk about continuity of care, when we talk about the Mission Act, and when we talk about other forms of healthcare, having that continuity, having it close to home gives you a better outcome for both the veteran and their families. And so it's not just treating the veteran, but it's how do you get a better health outcome on the long-term recovery, reduce the recidivism rate of veterans who go back for care. It's more likely that a person's going to go back to care if they're local than if they've got to drive 2 or 3 hours away to get their care, even if it's specialty care. That's the other component of the Mission Act, which was, and I know that there's a lot of debate right now with the Elizabeth Dole Act, that there was a big component in the Mission Act about caregiver support. So the Mission Act was more than just local health care. It did quite a number of other things.
Yeah, and also, in addition to what Jim said, especially when you're talking about specialty care, you talk, cardiac, critical cardiac care. If the VA doesn't have the volume of veterans coming through to kind of maintain the right word. But to be competent, a provider has to, routinely perform certain activities. And a lot of VAs are right across the street from major medical centers. And they're also have academic affiliates who are, literally blocks away. And so, if there is a cardiac specialist who could take care of veterans on in a high volume type setting, just the just what that saves the government from having to try to recruit and retain a high specialty who wouldn't have the right volume going through is another aspect as well. And you just talk about traveling. Think about going 2 hours to get a hip replaced, and then you have to go home. That's that those kind of scenarios are what makes Mission a good program.
Yeah.
Thanks, Christine. And
you don't want to go to the guy who's doing 10 hip replacements a month. You want to go to the female surgeon or the surgeon who's doing 100 a month. And it's not just the surgeon, but it's also the support staff who get you through that. I'm going to do a nursing pitch here. You want to get the nurses who are doing it and seeing those patients on a regular basis too. So again, it's a volume thing.
Great
and
pitch,
the
Jim.
social worker.
Yeah.
I've got a social worker sitting next to me who just glared at me, and then the social work staff who are more supportive of that type of treatment too.
Well, Jim, I know it's something you and I have talked about before quite often in about those outcomes. It's all about relationships sometimes as well. In those communities, you have relationships that you can build with those doctors who you see often. You're not going to a big center where you can see getting seen by a new person every single time you go there. So outcomes have been a big part of this. And I know, Christine, if I can ask you a quick follow-up on that, the VA model has been kind of under fire sometimes in this discussion. And they retort often against Mission Act is saying, "Oh, we're going to privatize what the VA's purpose is and what you're doing," even though the Mission Act was kind of meant to supplement what the VA model is doing and kind of work with them. Christine, can you talk to me about some of the issues surrounding that argument about why some people are upset about the future of what that Mission Act means if it's successful, as it grows and becomes more successful, what that means for the VA and how they're still working together very closely in both community care and the VA at the same time?
Well, yeah, definitely. Like I said, it is a supplement. I think we intentionally kept VA as the kind of the core coordinator of care. It's not just go out and find whatever service you want and make VA pay for it. There's a coordination element there that we required. Kind of like almost any other healthcare, you just even just straight insurance, you usually can't just go and luxury. Not that I would call that any kind of medical service luxury, but just kind of those kind of choices. So as far as there's never an intent to privatize, and like I said, if anything, we've shown that by having VA work closer with its partners and capitalize on what they do well and what the community does well, I think everyone has won. It's VA's primary care and mental health care is probably the most robust in the country, and I think that's kind of the entryway to some of the other, like Jim was saying, the more niche specialties. But VA's core primary care and mental health is very strong.
Thank you, Christine. And just a quick shout out to everyone on the call right now. If you have questions, feel free to put them in the chat. We'll get to them here in a second. We're going to do a couple more questions on the panel here with these two, and we'll open it up to some questions here from the floor. But Christine, thank you. And an excellent point about how it's a symbiotic relationship, having a good, strong community care program with a strong VA model working together hand in hand. I think that's very important to emphasize.
I want to piggyback on that, but also on something that Christine mentioned earlier.
Sure.
Which is about the tide rising all boats. I think we've got 17.5 million veterans or 17 million veterans in the United States today. The VA has about 9 million enrolled. As America's Warrior Partnership, our focus is on building a relationship with veterans, but I think the VA should, and programs that can get veterans to enroll in the VA, even if they're using the Mission Act. Predominantly, or if they're using the local. The key is that they're enrolled in the VA and there's a means to communicate with the veteran in the future to tell them about new programs, tell them about options that are available. The fact that almost half of the veterans in the United States aren't connected to any VA service or any VSO is if there's a program that the VA can have that can serve as a as a magnet to bring veterans in and get them connected into the system. It makes us a better country, and it makes us a better program system.
Absolutely. Jim, along those lines, real quick, another question. I mean, Christine and those who are on the Hill wrote a great law, and it was passed into law and signed into law in 2018, and then being the implementation of that. So even the best laid plans, as those in Congress will agree, it all comes down to how agencies implement and put the thing going forward. So as soon as the program Mission Act started going forward, AWP was receiving quite a few calls and requests for using use of the community care programs under the Mission Act. Can you describe some of the problems that became apparent right toward the beginning, and then Christine, I'll probably ask you about some of the implementation issues and some of the problems with referrals here as well in a minute.
Yeah, well, I would just say that the VA is an enormous system. It's an enormous bureaucracy, and I think the biggest thing is how do you get into that bureaucracy, but how do you get everyone informed about a new change in a law or a new program that's available to you? And I think there's a couple of pieces in the current agreement. I believe like the TRICARE, like the not TRICARE, but the like TriWest and Optum, they're literally just they're schedulers. The VA has the relationship with the veteran. There's no other communication going on about it. If the veteran doesn't ask about the Mission Act or another or that doesn't ask for a local appointment instead of waiting or traveling too far, I don't think that there is anybody there. That's why it's important to have these, like a call like this today, is that there's so many people on this call today that are advocates for veterans. And if you can arm them with the information to say, hey, wait a minute, there's an option here. I know you say you have to wait, and I know we have to travel, but there's this thing called the Mission Act. Can we use that tool to get local health care at more local area, in more of a more locale to their hospital? And I think for us, when we started to see, especially in the communities, how do we navigate the system? How do we get the VA to say yes? How can we use the service and not get stuck in an endless cycle of not being solved? But go ahead, Darryl.
So I was just going to push the question over to Christine as well. I mean, Christine, I think HVAC was right there at the forefront, doing great oversight on the VA as it was being implemented, but it was kind of a delayed implementation. And since then, there've been some problems with referrals. Can you talk a little bit more about kind of the eligibility for the process going forward, but how veterans can use the Mission Act now, how they can request going forward, and some of the information that we could, for those on the call, it's good to know on how to use it effectively going forward.
Well, VA did a very coordinated rollout of the program. They had to have it implemented a year after the bill was passed. And, started out strong, but again, you have over 350,000 VHA employees, just the health side, making sure each of those employees know all of not just the law, but also, VA sends out directives. Sometimes their own leadership sends out directives. There's sometimes the communication isn't all that clear. I've been to multiple VAs around the country, and you can tell a medical center with strong leadership and strong partnerships in the community, because it seems to have a pretty straightforward, rather streamlined, rather robust ability to refer the community, to get the veterans back in the VA, to kind of just use all those pathways. And then when you have another medical center where there's some resistance to sending veterans to the community, or some bias against it, you do see that there's less transparency to veterans as to what they're eligible for, what they could ask for. I just, Jim mentioned Augusta. I've been down in Savannah, and Savannah's 2 hours away from Charleston, which is the medical center for any specialty care. That's 2 hours. There were quite a few veterans down there who had no idea that they had this option to ask for treatment in a medical facility literally 2 miles away. So it's things like that. And I go to the VA website almost daily, and even though I know what I'm looking for, it's hard to find things. And just the kind of the old website used to have front and center, what mission meant and what it meant for various types of care. Now you got to do a little searching for it, and you got to kind of know what you're looking for. So that's another little provision we have in our end of year package. Hopefully that will be going here, at least in the beginning of next year. Trying to get VA to be a little more forthcoming as to what people are eligible for, what they can ask for, it's like I said, it's hard to find this information, but once veterans know what they can and can't ask for, veterans aren't shy. If they see that there's an opportunity to get care quicker or closer, if that's what they want, they're going to ask for it.
Well, Christine, Jim, let me ask you both this next question is kind of a hard one. Right now, just I went online, and the current wait times nationally for a primary care appointment at the VA right now is 29 days on average, 35 days for specialty care, and 34 days for mental health care. I think nearly every veteran out there and almost everyone in Congress agrees that it's probably too long to wait for these veterans who are looking for access to care. What is the process? So if you are one of those veterans out there right now, or you're counseling one of those veterans, how would you tell them to go about using the Mission Act options that are out there right now to access care? Is it just as simple as calling in and saying, hey, look, guys, I want to schedule an appointment for primary care. The wait time too long. I'm going to request primary community care under the Mission Act.
Technically, yes, that's and every medical center has it's an IVC, Integrated Veteran Care Office. It used to be called Community Care, but every medical center has those. They have patient advocates, they have veteran experience officers. There's multiple avenues. Primary care, if you can't get into primary care, and usually getting into primary care for VA hasn't been, if once you're an established patient. New patients there may be some wait, but there's multiple avenues to at least request. And then again, part of our legislation going forward is going to require VA to, if for some reason there's a denial, that reason needs to be very clear and clearly stated and explained.
And Jim, I know you've worked personally with this at times before. I know there's been problems with both appointments for community care or at the VA that have repeatedly been canceled or postponed or canceled without telling you, and you drive all the way out there, have it canceled right on you at the last second. Tell us about kind of some of your experiences that you've seen and how the eligibility for Mission Act really makes a big impact for some veterans out there.
Yeah, I think I agree with Christine. I think it needs to be easier. The website's really pretty difficult, but I mean, if care of veterans is front and center, maybe it should be a little bit more front and center on their website and both in their website, but in their facilities. I always, when I was out in the Navajo Nation with the NANASBA partnership with our team out there, and I talked to a veteran who he drove. So communication is really bad. Number one, cell phone service is almost obsolete. Not a lot of internet connection. Had an appointment in the Phoenix VA, which is a pretty arduous drive out of the Navajo Nation down to Phoenix. Gets down to Phoenix and he's told that his appointment was canceled a week before. And so then it's a 4-hour drive back. And anyways, the point is he could have gone to Gallup, which is a heck of a lot closer to get the care that was needed. I think navigating the system is really difficult. I'll give you an example. I have a veteran that I've been helping who had an appointment. And he had to cancel his appointment, his MRI appointment. When he went to reschedule, they had a number on his piece of paper, and then when he went to reschedule, he'd call, the phone would answer and then hang up. Phone would answer and then hang up. So it went on for like 3 weeks, and then he came and he said, "Hey, can you help me?" I went and I called the number, and the person picked up on the first call, and I said, "Oh, this is great. This is what's been happening in the past." And the lady who was the MRI scheduler, said, "Oh, I've been on vacation for 2 weeks." They must have been overwhelmed in their scheduling, and they would just pick up the phone and hang it up, and go through the process. How many, you said 340,000 employees, Christine? The problem is that
About that.
yeah, is that 330,000 employees may be awesome, but if you have 10,000 employees that are picking up the phone and hanging it up and not answering it to say, "Hey, can I help you?" It sort of sets the tone for everything, whether it's local community care or whether you're getting care on a national basis. The point is that if we're going to do it, we just need to do it right. And if local care is not available within the access standards, both on distance and time, then the first thing should be, well, let's get you an appointment locally. Christine talked about Savannah. We have the Panhandle of Florida. Panhandle of Florida's got 197,000 veterans live in the 6 counties around Pensacola and Eglin Air Force Base. There are local VA medical centers in Biloxi, Mississippi, which is like an hour-and-a-half drive away. But they're going to pass on the way from Pensacola or Gulf Breeze. They're going to pass Pensacola. They're going to pass Mobile, Alabama, that has a few medical centers, and then they're going to get to Biloxi. The point is, our motto is together we can do better. I think together with the VA, we can do better. There's people on this, I see some of the chats here. There's people on these that are advocates, and I think that the advocates in the community need to be really well informed on how to advocate for the veteran to get access to their services. It's really difficult when you're the vet to advocate for yourself. You don't want to be demanding, you don't want to be rude, you don't want to be pushy, but when you have somebody in your corner who can advocate for you, it makes it a little bit easier to sort of, I used to say when I was in Augusta, if we had veterans issues, I'd go down to the director and stand on his desk and say, we need to do better. But I mean, not saying that we should ever do that, but sometimes there's a point at which you go in and you say, hey, listen, I know we can work this out. This is what I have going on with the veterans that I'm advocating for. Can we figure out a way to move forward? And I think that the Mission Act has gone a long way. I think the success of it is in the fact that recently, I think it was 6 months ago, didn't the VA overspend their community care budget, or they exceeded their budget on community care? Looking at Christine for a nod. I don't know if I'm right or wrong, Daryl.
So just to follow up, so the Secretary of the Veterans Affairs said that the amount of spending, the rate of spending on community care was more than they had budgeted for. It was going to have to take out of some of what the VA model was, the traditional brick and mortars budget was, because it had become so popular. So community care, obviously veterans are voting with their feet and going to community care more often because it's successful and the program's working.
But again, community care only makes up about 30% of VA's healthcare budget, and I will say that Congress has been extremely generous with the VA over the past few years. So when there's discussions about there's not enough money, I'm not sure where that money's going if that's the case. Because again, yes, community care can be expensive, but it also, when you consider, things like, say, a cardiac surgeon, you're not paying their retirement, you're not paying their liability insurance. There's multiple overhead that sometimes isn't calculated in there.
Christine, that's a great point, especially with a $330 billion budget every year at the VA. There's definitely a lot of money there, and Congress has been very generous. So thank you for all your help with that, Christine.
Yeah, and
sorry, go ahead.
I just want to go back to what Jim said earlier. There's over 17 million veterans in the U.S. That number is going down, sadly, but then of that, there's only about 9 million who are enrolled for VA healthcare. There's only about 6 million who actually actively use VA healthcare. And by active means they at least go to the VA for care and treatment at least once every 2 years. A lot of veterans just use VA for prescriptions, et cetera. And then of that 6 million, only about 30% of those veterans use the VA exclusively. So, a lot of I don't need to tell the group on this call today, but there's a lot of misconception as to every veteran goes to the VA, and that's just not the case.
Christine, great point. Just to follow up on that real quick, I'm going to turn over some of the questions here from the chat, just some good ones that have been popping up. So thank you all for your questions. The first one, I think Rhonda has a great question, just to kind of clear up some confusion on the Mission Act. She asked, so what happens in the case when a veteran is in close proximity to a major VA, but the wait times are 4 to 6 months out for a mental health appointment? Can a veteran choose to go to a privately owned provider and then the VA pays? How does the vet go to the Mission Act? How do they become seen quicker? How does that process work?
Well, in that case, they have exceeded the access time for a wait time, access standard for a wait time. And it should be a request for a referral to a community care provider. And it should be honored. I mean, so, 4 to 6 weeks, 4 to 6 months, that's the standard is 20 days. That's not even close.
Just to clarify,
even if you live next to the VA, yes.
But the veteran should still call the VA first and make the request for community care rather than just going to the provider and paying, try to get reimbursement.
No, do not. Yes,
do not go direct to the provider.
That's not how it works. Yeah, and just anybody who that's just going and then expecting VA to reimburse without some kind of coordination prior is going to end up with a bill, unfortunately.
So
unless it's an emergency.
Big
difference.
Yeah.
But.
So there's a community care referral. You have to call the VA, get the community care referral approved. The VA will send you to a community care provider in the community that can see you.
They'll give you the option of going to the community, and they don't assign you a provider. You can work with the VA or work with the community to determine which provider you want to go to. But it does need to be coordinated with the VA.
Perfect. Thank you, Rhonda. And so Jim, Christina, along those lines, Hugo asked a quick question about what are some of the positive impacts as a result of the Mission Act? What are some of the numbers that have changed? How many people are using the Mission Act right now? Christine, do you have any of those numbers? And Jim, have you seen any stories from veterans who have really had a positive experience from the Mission Act overall?
I don't have the numbers in front of me. I mean, we get the numbers briefed to us continually. It's robust. It's needless to say, but and I think we've had a lot of great stories of veterans who did get access to something they needed, and especially in the specialty care area.
Yeah, I agree, Daryl. I think that veterans, for the most part, that have used the Mission Act have been happy with it for a couple of reasons. One, they can go back. So it's not just a one-time appointment. It's you can go back for recurring appointments around a set condition that you have. And I think that's number one is awareness that it is. Number two, again, I think that what we're doing is a total. I think local healthcare is key. I think trusted healthcare is key. Do not, I'll reiterate, don't send somebody to a doctor and hope that the VA is going to pay after the fact. Work through the system. I'd love it for everybody on the phone. If you have a veterans and they're struggling, or you're struggling to get veterans access to the Mission Act, I'd like to hear back from you. That we're having an issue. I think if one person is having issues and nobody says anything, it never becomes an issue. But if you're advocates and you want to send to us and say, hey, send to AWP, say, hey, I can't access the system, we can then, consolidate the opinions and maybe advocate for a change. I think it sounds like, and I read down through the things, it sounds like a lot of the issues are accessing the service. That it's number one, what I hear from a lot of veterans when they do ask is that number one, it's not offered, or number two, it's no, you're not eligible when you're actually eligible. And again, I'm just saying that in terms of having an advocate, it's a good thing to have somebody who says, no, you actually are, and who knows the system. The VA system is extremely complex. And so to expect every veteran to understand how to navigate it is unreasonable. I think for the people that are advocates for veterans to be informed is really something that needs to be done. And if you advocate on the local level and you still aren't getting results, let us know. We'll package them all up and send them to Christine.
that's our job. That's our
And
job.
there's
Yeah.
also, but you also have, you have resources through your district member's office. They have caseworkers who have usually very good contacts with the local VAs there. So if you do have a problem, that would be where I would recommend starting, either that or with an advocate. And then when a district office starts to get frustrated and not get the right answers, then they usually elevate it to us. And it's kind of sad. I mean, we've had several cases, and we don't typically do casework, we're more policy, but there have been a couple of cases where back and forth between the VA 3 or 4 times, and finally at the end, it's, oh yeah, they really were eligible the whole time along. And you're like, really? So, but as advocates, I really appreciate what all of you do, and I understand some of your frustrations, having seen it myself. But that's a kind of a good path to follow, at least to get started.
Well, Christine, that's actually a great segue, and Jim, you kind of referenced this too. Alexandria has a question, and I think it kind of gets the heart of what you just described. Who ultimately makes a decision whether an outside provider or program is more appropriate for the veteran? Who makes that decision in the VA, whether or not to be able to refer or keep it in house?
I'll answer that one.
Yeah,
And
it's a great question. Thanks, Alexandra.
If it's not something that's kind of black and white, i.e., a wait time or drive time, it's supposed to be between a discussion between the veteran and their provider, typically, primary care provider, and that decision is, they kind of agree to that this is in the best medical interest for that veteran, and then a referral is put in. Again, another element that we're looking at for mission improvement with this end of year package is that when that decision is made between the provider, the clinician who knows the veteran, and the veteran who knows what they need and want, that decision can't be overturned by some bureaucrat further down the line.
yes, we love that. Because the next step beyond in the current system, it does go up to the next level of review. So it can be overturned above the physician but the bill that Christine's talking about has it in it that it's solved when that decision's made. It's not. There's not the ability to overturn. Yeah, that's
very helpful. Thank you both for answering that question. I know that's kind of gets the heart of some of that issue. Brittany out in Dina Nazba had a great question too. Are there any priorities for the Mission Act for Indian and tribal organizations and those in other underserved areas to help ensure that they also have good access to care?
I would say for both Mission and any of the bills we've been doing in the past few years, we have been very cognizant of including tribal Indians, urban Indians, Alaskan natives, and and underserved communities. We've been very cognizant of trying to focus on that area because so many of the members on our committee actually do live in those areas.
I think, and Christine, you were out in the Navajo Nation. There's the Bureau of Indian Affairs, and the clinics that are there, and they have veteran clinics, and then there's the VA clinics that are actually outside of the territory. Do you see? Is it it's not the same criteria for the Bureau of Indian Affairs facilities as we're talking about with the VA. It's a different process.
I'm not quite sure. Yeah.
Yeah, and so I think a
lot of them are through MOUs, memorandums of understanding and agreements. And, we have been trying to, get the partnerships between VA and Indian Health to be a lot more streamlined.
Yeah, I think that's what Bernie's talking about. Is there anything, because, we've had cases in the Navajo Nation where a veteran can't get care within the VA clinic of the Bureau of Indian Affairs clinic of the nation's clinic. And then they have to go, they go outside to a CBOC, which is outside of the reservation or outside of the territory. And they were denied because they're being pushed back into the territory to get their care. I think that's where Bernie's asking, but we'll follow up with you on that.
Sounds good. And then if I can ask one last question before we close up the call here, Christine, I know you've been working this for a long time, and as Chairman Boston and yourself are writing the legislation right now going forward for some of the reforms to the Mission Act. Can you tell us a little bit about the Veterans Care Improvement Act and the Health Act in the Senate, and kind of what those reforms are looking to do, what they include, what that package is, and what might be included in the final end of year package here? Any clues or insight will be welcome.
Yeah, we're still working through that, but I noticed one of the questions was asking what the bill numbers are. Let me have it right here. Let me see.
Perfect.
My eyes on it. And so those bills, if you go to congress.gov, and we've got the House bill is HR 3520. The Senator Moran's bill is S 1315, and Senator Tester's bill is S 2649. And what we're doing is going through all three of those and trying to get as much agreement as we can. We're making some pretty good progress. I think we've got at least the provisions I mentioned today are supported. so that's a good news. And then I also see another question here. You know, sometimes civilian medical care wait times can be long or longer. Absolutely, don't argue with that. There's a healthcare crisis in the U.S. right now especially for mental health, and you know, fortunately, veterans do have good access to mental health, but you look at the other competing priorities in the country, and especially with the growth of teenage requirements and things like that. Yes, we do recognize that it could be longer, but in some cases, again, it's mission and choice is not a veteran has to go there. It's they have the option. And I think sometimes that's a bit of a confusing point. Some people say, well, you know, you're make me go to the community. A veteran doesn't want to go to the community. That is absolutely their choice.
Yeah. Hey, Christine, I just want to make sure HR 3530. Sorry, just because Allison put it up there, I want to make sure it's right. Sorry, say that again. I think you're on mute. You're on mute, Christine.
3520.
Okay.
And 1315 and 2649.
Okay, got it. Yeah. Allison, you get that? Yeah, there you go.
S 1315 and S 3520.
Yeah. And there's I think a really important question up here, Daryl. It's from Stacy. A veteran with suicidal ideations, especially for those who do not qualify for inpatient care. There is a bill, actually there's a law, I think it was signed in, I can't remember the name, but it provided access for those who had suicidal ideations. All veterans had access, is that right, Christine? It wasn't part of mission.
Oh, the Compact Act?
Yeah.
Yes.
Yeah.
Yes,
yeah.
That's still going through some implementation growing pains on that one. But okay. If you're in a mental health crisis and need help immediately, that's one where a veteran can go and seek care without having to get a referral.
Yeah. So Stacy, that would be the answer to your question there about a veteran has suicidal ideations and not having difficulty accessing care. They can go to any ER or any facility, emergency room facility, to receive care and be reimbursed by the VA for it. And it's called the Compact Act.
Compact.
That it came out in. Yeah. Daryl, before you close this out, I want to say to everyone on this call, I've had the luxury and the pleasure of working with everybody on the Senate side and the House side in terms of developing and providing education and information that we have around as they negotiate and navigate these bills, and to bring them together into one bill that's going to get signed, or one act that's going to get signed into law to be implemented. And I will tell you that Christine is an example of everyone that we work with, and is a shining example of everyone we work with, that they are absolutely advocating for the veteran and their family, 100%, and they're fighting the fight, and they're doing it in a transparent manner. So my hat's off to Christine and her team, and the folks who are advocating for us on Capitol Hill to create laws for the VA to implement to provide better care for our veterans and their families. So thank you, Christine, for all you've done, all you're doing. Okay.
And thanks for all you do as well.
Well, Christine, Jim, thanks. With that, I'll turn it back over here to Allison in a second to close things out. But I just want to personally thank you both. Mission Act, I mean, anything touching VA healthcare can be very complex and confusing. Thank you for being on the call today to help explain what that is, why it's important, and how it impacts so many veterans. And thank you for all your hard work, both implementing it, writing it, drafting it, putting it together, explaining it, everything. So thank you both. Really, thank you.
Thanks, Christine. Thanks, Daryl.
Thank you.
Thanks, guys.
Yes, thanks, Daryl, and thanks to everyone. I want to thank Daryl, Christine, and Jim for their informative panel. Our next battle rhythm is going to take place on January the 8th, 2024. Can you believe it? I'm in the process of getting next year's plan together, and I'd love to have you guys give me your suggestions. So I'm going to send out a poll right now. I'm going to share out. Please give me any suggestions you would like to hear for next year's battle rhythm. It's just what topic should we explore next year? And while you guys are answering that, I'm going to thank you for attending and asking such great questions. America's Warrior Partnership's ultimate goal is to improve the quality of life for all veterans and end suicide by empowering local communities to know their veterans and serve them holistically before a crisis occurs. America's Warrior Partnership's model of community integration amplifies local effects by bringing the communities of veteran serving organizations together to bridge the gap in available services and connecting local groups to national resources. We believe that communities are the best place to equip to improve the quality of life for veterans. That's why we hope that today's battle rhythm provided you with powerful insight, information, and new partners to do just that. Thank you for all you do, and have a great rest of your day. I'm going to leave the poll up a little while longer. Please give me some feedback. I really love to hear from you all. Have a great day. Bye, everybody.